So I think we've got quite a few people on the call. So let's make a start. I'm really delighted to welcome Professor Malcolm Walker, who many of you will know from his long-standing interest in cardiac complications in patients with thalassemia and sickle cell disease, in particular the very influential work that he's undertaken in monitoring and treatment of cardiac iron overload in hemoglobinopathies. Professor Walker probably doesn't need any introduction other than to say he's made a huge contribution to this field and has been influential in contributing to national and international guidelines, including the TIF guidelines and the national standards in the UK. And we're delighted to have you with us today, Malcolm, and very much look forward to your talk.
Good. Well, thank you, Mark. Thank you, Mark. There's a bit of echo. Is that? Thank you for that introduction. That's very kind, and it is a great pleasure to give this talk. And I'll start with an apology. I always feel slight trepidation. A cardiologist venturing into the field of hematology, and I will apologize a little for the first part of this slide. This slide set that I'm going to talk, because I often, or I have given the most recently this particular talk to cardiologists, and most cardiologists require a bit of an update on hematology. So I'm going to go through those sort of very, very general introductory slides. There won't be any surprise to you that work in hematology, and I hope they're not too naive, but it is a cardiologist view of some aspects of red cell hematology. And I start by saying this is a big problem. 7% of the world population carrying inherited disorders of hemoglobin of one sort or another. And the spread is not equal. And this is WHO world map. The color, the red being the very high incidences, as you can see in that little plan. And you can see that there is a very distinct distribution along the equatorial regions, but with modern travel, there isn't any country in the world that doesn't have an incidence of these conditions. However, I think this still is true, and this is really a big motivating factor in a lot of the work that we've done, is that 80% of affected infants live in the poorest parts of the world. So these are old estimates, forgive me for that, I haven't updated this in a while, this particular data. 300,000 children born per annum with a severe hemoglobinopathy, with homozygous sickles being the largest single group. And that's what we're going to talk about this afternoon, although the majority, I cut my teeth primarily on the thalassemias. Clearly, clinically, and numerically, the sickle cell conditions are numerically numerous and pose enormous problems, which I think you will appreciate as I go through this. And this always intrigued me, and this was always a fascinating bit of epidemiological and clinically based research, and that is to do with sickle cell mutations and why they are distributed the way they are. And it was very early work in the 1950s that suggested that heterozygosity of the sickle mutation carried an advantage over normal hemoglobin in resistance to falciparum malaria, and so that the carrier rate of the mutation tends to focus around areas where that is an evolutionary advantage. That is the areas where the falciparum mosquito. I suppose we'll have to redraw these maps with global warming and as these mosquitoes move northward. There's another interesting bit of work I did many, many years in my reading, and this is when Fleming and his people in Kano district, they found 2% of births were homozygotes, but they didn't find a single adult in all their time there with the full-blown disease. the oldest patients was a girl aged 4. And the point here is that these individuals with homozygous sickle were not surviving at that time. However, again, this is important to note that the outcomes for homozygous sickle is changing even in Africa. And this is an important point from colleagues in Nigeria, which I'm sure some of you will be aware of. And this is looking at actually hospital admissions across time and how they've come down this is in Nigeria, and essentially not with any medicine as such or expensive drugs, but with a better education, with some penicillin prophylaxis, an immunization program, and recognition and early treatment of infection, making a big difference to children. With a reduction of mortality and reduced hospitalization. So important economic aspects, and making the point that it's not necessarily very high-tech medicine here. We're looking at just good clinical care. And you will all be completely aware of this, but this is something I have to remind cardiologists, and then what it looks like with red cells and the abnormal hemoglobin breaking the red cell membrane and producing the classical sickle appearance. Now here we start getting into the different phenotypic expression, and there is, as you will all know, a complete spectrum, even within known single gene mutation, although there are lots of mutations, the single gene affected. The spectrum of complications is rather variable and looks to be mysterious until you begin to understand some of the other confounding variables, including the presence or absence of other hemoglobin mutations, in particular the alpha thalassemia trait, in particular shifting the phenotype away from, if you like, the more hemolytic picture that is associated with endothelial dysfunction, higher hemolysis, higher plasma hemoglobin, and greater tendency for pulmonary hypertension and strokes, and moving it towards a phenotype that is more vaso-occlusive in its presentation. And these kind of understandings help you manage and to begin to get a clearer idea that there is a variability in the phenotypic expression, and it depends on other covariants. Not terribly surprising, but it's very important to bear in mind. And this also allows one perhaps to focus on individuals and see where they fit within this spectrum. So let's now get to the meat of what I'm supposed to be talking about, and that is the heart. And this is a very simplistic diagram, but it does make a point. And it's common to hemoglobin defects in general, but I'm going to talk specifically about sickle cell conditions here. And the first thing that I'm going to consider is the situation of what we call a persistently high cardiac output precipitated by the presence of an anemia. And it's important just to bear this in mind, because this is the background upon which a lot of other issues arise for the hemoglobinopathy patient. And I think it's not surprising, and we all know this, that chronic anemia is associated with an increased cardiac output. And this may be as high as 60% higher than a non-anemic individual. And the way this is achieved, if you like, is by having a higher volume of the ventricle in end diastole, and therefore as the heart contracts with a higher starting volume, you end up with a bigger stroke volume. In many instances, but by no means universal, this is written and copied from paper to paper, but increased heart rate. Actually, I haven't got the data to hand at the moment, but I think this is probably wrong. And although it may be true for anemias that occur for other reasons, like iron deficiency, it doesn't appear to be necessarily quite as true in hemoglobinopathies. And that, again, relates to the control of the circulation, which goes awry in these populations of hemoglobinopathy patients. So what's it like to live with a chronic high cardiac output state? it's difficult. It of itself, in the extreme, it can generate cardiac failure, and we see that occasionally in thyrotoxicosis, where you get an enforced, a very significantly high cardiac output, which ends up with a tired heart, if you like, and heart failure. But with these chronic anemias of a more modest degree, the cardiac output is chronically increased, and it does lead to changes in the compliance of the arteries. And this is important because the reflective pressure waveforms then end up with what we call restrictive physiology of the ventricle. That basically means that the heart becomes stiffer, and you end up, if this progresses and continues over years and possibly decades, in dysfunction, diastolic dysfunction in the relaxation phase of the heart. And if you carry on with this situation, you might end up with the situation where you have the awful acronym of heart failure with preserved ejection fraction, HuffPuff, where you get the syndrome of heart failure with breathlessness, edema, raised JVP, congestion, but the pump, the ejection fraction, the systolic pump is maintained. And this is all related to stiffening of the heart and the development of this restrictive physiology. I'll just have you know that this is not an uncommon phenomenon associated with non-sickle populations as they get older. In significant old age, the 7th, 8th, and 9th decades of life, this physiology is very common, and it's increasingly seen and very, very commonly associated with other situations that increase the workload of the heart, such as hypertension. And in some respects, when I look at a heart of a sickle cell patient, you actually can see in terms of its physiology, it looks like an 80-year-old non-sickling heart in many instances. Slightly big, very stiff, tendency to congestion. So in one simple take-home message, on average, a sickler's heart is at least 20 years older than their peer group without sickle. So I'm just going to look at some data out of our clinic. Historically, actually, this has gone up a little now, seeing about 300 homozygous sicklers per annum in the clinic. There are, in the immediate sector of our clinic catchment area, about 11 to 1,500 patients. And just some simple data was done by my colleague Mark Westwood, now Professor Mark Westwood at Barts, published many years ago, just showing that the end diastolic volume index in the sickle compared to the thalassemia, compared to normals, the volume, the stroke volume index, that is just the stroke volume that is normalized for the size of the patient. Stroke volume is higher, ejection fractions not higher, suggesting that although the heart's pumping out more blood per beat, its overall efficiency and ejection fraction tends to be lower than normal, suggesting perhaps that we're already seeing some long-term effects. And the cardiac mass is higher, so the muscles are bigger and thicker and the hearts are larger, although the ejection fraction may be lower. In one of the things that happens here, the heart is chronically volume overloaded, and that causes dilatation in order to compensate for the anemia. Hearts are bigger. Why do I emphasize that? Because so many of our patients in the sickle community and other hemoglobinopathies go along to have a chest x-ray having developed a chest infection. The radiologist reads no further than chest infection and says, oh, your heart is big. The patients panic and they're sent along to clinic. The heart is necessarily bigger in a chronic anemia, and this is a compensatory mechanism as long as it's still pumping well. We do see stiffer hearts with a late complication of diastolic dysfunction, which we'll come back to later. The aorta is a very compliant tube. That's a very important aspect. In all of us, I'm afraid, as we age, that compliance diminishes and the arterial system gets stiffer. In this group of patients, that happens much earlier, and probably at least 20 years earlier. Those major arteries being stiffer has a consequence with the reflective waveforms being different, and that's one of the reasons the ventricles get stiffer. Because they're anemic, they tend to have a low systemic vascular resistance. So often, not in this group so much because it's more complicated, but in chronically anemic people, blood pressures can be somewhat lower than you might otherwise expect. And there might be a tendency, because of the vasodilatation, to congest the lower limbs, ankle swelling. The other thing just to note, when you get a report as a non-cardiologist, get a report of an echocardiogram that says normal ejection fraction, in the normal population, the median ejection fraction is between 55 and 65%. In the group of hemoglobinopathies, we know now that the lower limit is a bit over, it's actually 63%. So if you get someone who comes back with an ejection fraction of 55% and someone just scribbles normal, just bear in mind that might not be normal, because their heart should be pumping more than normally to compensate for the chronic anemia. Those are important management issues, because sometimes things going wrong are not picked up early enough because people misinterpret the data. In our hospital, a huge proportion, I suspect elsewhere also now, sickle cell patients have long-term transfusion programs, which certainly from a non-hematologist looking after these patients can have a dramatic, can have a dramatic effect on quality of life, reduced admissions, reduced complications, fewer sickling crises. There are disadvantages, you know, the commitment, and then it's but no little you know, inconvenience to them, particularly if they're working or have young families. And as you transfuse, you do run the theoretical risk of overloading tissues with iron. So I'm going to briefly mention iron overload within sickle, because it's something that will come up in a moment. I'm going to show you a few clinical examples later, case histories, where this was an important factor. As you will know, you've got transferrin, which is normally saturated somewhere under 30%, but with chronic transfusion, that saturation then rapidly rises and is overwhelmed, and upon which, when that happens, you get appearance of non-transferrin bound iron, which then has a tendency to accumulate in various organs, the liver and the heart particularly, not so much pituitary, parathyroid and gonads, I think, in this population, because this happens late compared to the thalassemics, where they're transfused from infancy. And as Mark kindly mentioned earlier, I was involved very, very early on using what was then a new technology of MRI scanning, and with a research fellow, Lisa Anderson, that worked with us, and between myself and Dudley Pennell, we worked out, this was known already, that you could directly measure iron using an MRI. You can measure it non-invasively in tissue, looking at the decay of the MRI signal. The speed at which the signal decays, gets darker, is a mono-exponential, and that from that mono-exponential you can derive the rate constant, and that's called the T2 star. And just take home messages, an MRI T2 star is now and has been shown to be the global standard for tissue iron assessment. And in the heart, in the T2 star for a non-transfused population is around 35 milliseconds. And we know from a lot of work in the thalassemia population primarily, that T2 stars over 20 milliseconds, there's an extremely low risk, if not zero risk, of cardiac complications from the iron. And if it's as low as 6 milliseconds, which is severe iron overload, that poses a about a 50% risk of developing heart failure within 12 months of having a T2 star at that sort of level. Just one caveat, the T2 star and iron content's not linear. So if you have a patient with a lot of iron in their heart with a T2 star, say of 4 milliseconds, if you treat them and it goes up to 6 milliseconds, that doesn't look like much, but because of the non-linearity, that's a 40% reduction in iron content. Conversely, if you have someone with very little iron, 30 milliseconds, and it increases to 32, that's an 8% reduction in content. Just bear that in mind, because patients can get, my patients used to get depressed if they went from 4 to 6 to 8. And I said, well, you've already reduced your iron content by a half. And others might be jubilant of going from 30 to 32. And I say, well, really, that's not really worth terribly much. That's just a little background about the T2 star. I'm just going to talk a little bit about vasculopathies, because this is really, really important. And historically, it was the main emphasis of, if you like, the cardiologist input into sickle cell. And primarily, I'm just going to focus for a couple of slides on pulmonary hypertension. There is a tendency in the sickle population to develop an obliterative vasculopathy, intimal hyperplasia, thrombosis on top. And this, you can see this in mouse models of sickle, where you get changes in the right ventricle. The cardiac output initially increased, then as damage persists in the older animal, cardiac output falls. And if you look at the pulmonary arterial pressures, they are much higher because of this accumulating vasculopathy, well, no changes in the atrium, but in the pulmonary arteria. So this, you can model this, and there are a significant number of models of the development of pulmonary hypertension in sickle cell animals. The etiology is really quite complicated, and there are many, many different features that lead to the end result in our patients of pulmonary hypertension. I'm not going to completely stick on these, but the long-term increased cardiac output increases shear stress in the vessels. That causes abnormal forces, and you end up with some vasoconstriction related to hypoxemia, some associated hypoxemia related to restrictive lung disease, problems with diffusion at the capillary level. You've got direct effects on endothelial function from iron, from increasing circulating platelets with their functional splenectomy. So you can see there are a number of factors, and a lot of these have been worked on and worked out in animal models and in the clinic. So you've got to remember from your medical student and your A-level biology days, this is what the cardiac circulation looks like, with a low pressure, high volume circulation on the right, and a high pressure, identical volume on the left. So for numbers, so you just remember, mean arterial pressure in the pulmonary circuit is about 15. Normal is about 25/8, compared to, you can more or less divide left side pressures by 5 to have an idea of where you should be on the right. And these are just to give you some idea of what we're looking at here. And historically, to achieve those numbers, to be able to measure those, required people like myself, this is an old picture, in a cath lab, invasively sticking tubes under local from the femoral vein up into the heart, or else we can approach it nowadays more commonly from veins in the arm or subclavian veins. By catheterization, you can measure the pulmonary pressure. But that's not practical, particularly in chronic conditions like sickle cell disease because there's some variability in these parameters, and patients will not and should not be subjected to invasive procedures on a regular basis. Thankfully, along comes the echocardiogram, which by looking at the tricuspid, this is the tricuspid valve here, the right ventricle here, this is a tricuspid jet. You can measure the velocity of the tricuspid jet if you get a lovely image like this, and you can work out because it's the pressure drop is equivalent to 4 times the velocity squared. I tend to get my technicians to quote the velocities because there are some errors here, and if you go down to get a pressure, you're adding, first of all, you're multiplying your errors, you're squaring them, then you're multiplying the error by 4, and then you're adding a guess rate as to what you think the right atrial pressure might be. So everybody looks at this, the systolic pulmonary arterial pressure, and that's what's quoted in most echo reports. But I would counsel you to go back to the pulmonary Vmax, which gives you clearer and less ambiguous results with less guesswork about that parameter. And I think I've got this in my next slide. Okay, no, maybe not. You're looking really in the sickle population, up to 2.8 meters per second is probably normal. Between 2.8 and 3.2 is borderline, and over 3.2 is really very likely to be clinically significant pulmonary hypertension. So hemoglobinopathies, prime candidates for the development because of release of free hemoglobin from hemolysis that causes the endothelial dysfunction, the associated hypoxia, increased shear stress, and a propensity for thrombosis. So it's a perfect storm. And so how often do you see it? This is from our study of our patients coming along that Mark Westwood published. 10% with a velocity, that's absolute normality. 4% with the more significant over 3. And there was a relationship, and it's variable with the recent crisis. And unlike other situations, like let's say, take for instance scleroderma, where you see pulmonary hypertension, in the sickle group, you often don't see ventricular hypertrophy or ECG change quite as commonly, at least not until pulmonary hypertension is fixed and firmly established. And you've got to be a little bit careful that velocities are affected by the degree of anemia. And this is what it looked like in terms of, oh, that's cardiac study. This is from Mark Westwood's thing. More recently, Emmanuel Acco, my research fellow, looked at, this is 127 sickle patients who were on an exchange or were on some kind of regular transfusion program over 10 years. And so we saw 9% of our patients over 3 meters per second. So these are pretty well pulmonary hypertensive, with 15% in the border region. So it's not uncommon, nor is it catastrophically common. And this is consistent with previous data. Then what you do about it, and that's the real problem, conclusive prospective trial data that you improve outcomes is really weak, if not absent. And so pragmatically, because of the many different factors, we consider anticoagulation. We will consider channel blockers, but they're often impossible because these patients are often hypotensive already, and then they can't tolerate them. 5-hydroxyurea was really mooted as being a potentially helpful agent, but there's no prospective trial, and it's very, very variable and with its own problems. Using phosphodiesterase inhibitors such as sildenafil and tadalafil can be very helpful in some individuals, but the walk fast trial was abandoned because of the incidence of priapism limiting its really wide adoption. We do use it, and we have a number of patients who have done extremely well with a reduction in right heart pressures on long-term PD5 inhibitors. Things like endothelin antagonists really are in the hands of the pulmonary hypertension doctors in places like the Royal Free, and are rarely used in this group. They are fearsomely expensive and difficult to take. So there's a number of different, but the options are pretty limited. So I think the take-home message here, we've got to do everything we can to stop our patients getting there. So you do need to screen, and if you detect the tricuspid jet velocity rising, our response is to optimize hematological care, often drive the hemoglobin higher, try and encourage patients to join transfusion and exchange transfusion programs if we can. Those that still do, and it's a surprising prevalence, should stop smoking. If they have hypertension, which some of them do by this time, treat that. And we do use vasodilators, and we do refer them for more complex therapies if we cannot get anywhere with these simple measures. So I'm just going to end with 3 case histories. These are real, they're recent, and they were collected by my colleague, Dr. Polyvios Dimitriadis, who actually is taking over my role at UCH in the red cell clinic. So we just put together these 3, and they demonstrate in particular beginning to understand how complex the situation is for the sickle population. Now, we focused here on our patients with left ventricular dysfunction and the different patterns that you might see, and it's much more complicated than just a little bit of restrictive physiology or a little bit of pulmonary hypertension, and I think you'll see what I mean. Okay, this is a youngish sickle patient. She's just 37, who'd been on transfusions, not a huge amount, but because she was quite phenotypically severe, had quite a high total transfusion load, and was looking at, this is the most recent one, but a very high ferritin, 11,000, and an overall trend of very high ferritins over long periods of time. And she came in with decompensated heart failure and had an MRI, as we would do in most patients if we can get it done during that admission. And we were a bit surprised. You might notice here that this is the left ventricle here. Number one, it's not pumping terribly well, and it's quite dark. And then when you put the liver and the heart, and this is a method of measuring T2 star, just using mapping methods. The T2 star was 4 milliseconds, hugely low. The T1 was also low, which again suggests a significant amount of iron overload, and the liver iron was exceedingly low. The liver T2 star was exceedingly low, suggesting a very high. The redder it is, the more iron in that particular scan. So the way to manage this particular woman's heart failure would be to include amongst the more conventional heart failure medications, chelation therapy. And as an inpatient, that was started with deferoxamine infusion. She had appropriate combination heart failure medication and underwent exchange transfusions to bring her hemoglobin up. She was able to get out of hospital, repeat MRI 6 months later. Her left ventricular dysfunction from severe has become mild with an ejection fraction from memories about 38 to 40%. And the T2 star has gone from 4 to 5, so a significant increase, and an increase in T1 as well, and an increase in the liver T2 star. Paradoxically, this is our fault. When the T2 star rises, the iron content goes down. That's been a bane of my life ever since we decided to express it that way, because people get very confused. But so adding deferoxamine to her conventional anti-failure treatment was fundamental for this young woman. Here's a different pattern. This is a 42-year-old man on exchange transfusions with a background of end-stage renal failure, high blood pressure, and he'd had some kind of cardiac event in 2018. And on a routine, because they have a routine echo, and they come to our clinic every year, he had severe left ventricular systolic dysfunction. when we try to look to the cause of this, it's a non-ischemic form, and that's what we get from these different mapping studies. There is no iron. The T2 starts 45 milliseconds. He does have some septal fibrosis, and the diffusely elevated T1 tells us that there is some interstitial edema. He was difficult to manage because by this stage he's got end-stage renal failure, and quite difficult to introduce angiotensin receptor antagonist drugs, the ACE inhibitors, the spironolactones, because we're limited by his renal failure. So a difficult management problem. And this, I think, will point out, as I'll do in the summary, this combination of a non-ischemic dilated cardiomyopathy with end-stage renal failure. Very, very difficult management problem. And sadly, a few months later, he comes back to clinic, and I think even those of you who are not used to seeing these sorts of images can make out the heart is much, much bigger, very dilated, and with extremely poor contractile function. We are discussing him because of his relative youth with our colleagues in complex heart failure management to see whether he should have a prophylactic ICD. There isn't much option to do resynchronization because his ECG is not broad complex. So very difficult. We're sort of powerless, but it tells you about the complexity of the cardiomyopathies in this group. Finally, this is a very sad case, 52-year-old, who actually I was speaking about this morning to his clinicians. He's had previous stroke. He's a very, very high functioning gentleman with a very medical family, presented with decompensated heart failure and severe left ventricular dysfunction. He has mildly deranged kidney function. His creatinine average is about 130 micromole per liter. These are his MRIs, and again, you can see very, very poorly contractile, but you might make out that the apex here is extremely thin, and it's also scarred, and you can see it in this view here, that the apex of the left ventricle is akinetic, and there's basically no muscle there. It's all scar. The CT shows that this is not due to conventional coronary disease or coronary blockages. He is in end-stage heart failure, an inpatient at the moment, and really we are at a stage where he's receiving palliative care because there's very little that we can do. So we've seen three patterns there: iron overload, dilated non-fibrotic dilated cardiomyopathy associated with renal failure, and an ischemic dilated cardiomyopathy not related to epicardial coronary disease, but probably related to microvascular disease. So although there's some common complications, we do see a small number, but very, very difficult to manage group with systolic dysfunction. And we are increasingly relying on the CMR to help us understand the etiology, which I hope in turn will help us understand how better to prevent these complications. Again, all I'll say is that if we start detecting these changes early, we need to optimize, that is, reduce the amount of hemolysis, increase the level of hemoglobin, ensure that all their hematological care is absolutely the optimal it might be, and try and support the ventricle if they're hypertensive to treat it intensively. The thresholds for introducing blood pressure treatment are much lower, I think, in the sickle community, and GPs will send our patients away, oh, your pressure is only 140 or 90. In this group, it probably should be nearer 120 to 130. And we try to use ACE inhibitors, beta blockers, aldosterone receptor antagonists, the combination treatments, and nowadays the SGLT2s, which may have a role in preventing that stiff heart syndrome. And we keep in mind advanced heart therapies, ICDs, resynchronization when we can. So this is a lifelong multi-system disease. It seems that those individuals who are treated intensively hematologically do better. However, this heart is facing a lot of problems through its lifetime, and we need to do the simple things first. A lot of people involved in this experience, with the most recent, who you'll hear again, I hope, and be able to liaise with, my colleague Polyvios, who's taken over my role at UCH in this regard, although I stay in the background. They haven't got rid of me yet. So I'm going to stop there. This is his slide, a little manipulation of a left ventricle from an MRI. If there are any questions, I've got time for questions, I'd be very happy to take them.
Thank you very much, Malcolm, for that fascinating overview of a subject which I think, as hematologists, we're seeing increasingly in our clinical practice as the age of the patient population advances. I'm sure there will be some questions, but I wondered if I could start by I was very interested in your data on pulmonary hypertension in patients who are on regular transfusion programs, and whether you have I know there is an NIH study which is looking at the potential role of red cell exchange in managing cardiovascular risk in sickle cell disease. But I wondered if you had any impression as to whether patients with the sort of cardiac complications that you've described would do benefit from red cell exchange.
We do. Emmanuel Ako's study, which oops, there's a bit of an echo. Emmanuel Ako's study, which I've never forgiven him because he never got around to publishing it properly. It's been in a couple of abstracts. This was a group altogether, I think it was 127, who'd had at least 10 years of being on red cell exchange program. They were really very well treated. And that's what that came from. About 10% or less had significant pulmonary hypertension. There are very few in that group who had very severe clinical pulmonary hypertension. They just had elevated tricuspid jet velocities. That was the 11% of that. What was clear from that analysis was that the main, within these exchange patients, the main predictor was something really, really simple. It was systemic hypertension. And my analysis is that by doing the red cell, the quality of life, the number of sickle crises diminishes, but you are still left with some of the longer term consequences, the restrictive physiology, the diastolic dysfunction of the left ventricle, which then leads to pulmonary hypertension in this group. Now, that's in some respects a positive thought, because if you were to aggressively treat conventional cardiology like hypertension, the prospect is that you might be able to make an impact in that outcome. So even though it initially looks surprising that there is a 10% incidence of elevated tricuspid jet velocities, it's not of the catastrophic type of progressive nasty pulmonary vaso-occlusive form. I think it's related more in that group who are older to the development of left ventricular restrictive physiology. That remains to be proven. Very difficult to do, but you know, it would take probably a group like this doing some kind of registry studies in people who are intensively treated from a young age to make sure all their cardiovascular parameters were kept absolutely under control over a long period of time.
Thank you. We've got a couple of other questions. First from Mercy Ividapo.
Oh, thank you very much. Can you hear me?
I can.
Thank you so much for your talk, and I want to thank you for referring to the paper on outcome of holistic care in Nigeria. I happen to be one of the authors. Thank you. That was so encouraging to me. My comment is the use of tricuspid regurgitant velocity in echocardiogram in sickle patients. The specificity is about 33%, but I've heard in talks, and I don't know what your comment about is, adding on NT-proBNP increases the specificity to about 61%. And I think this would be of practical use to clinicians. So, and I wonder what your comment is about, considering the hazard of doing cardiac catheterization in this lot.
Yes, I virtually don't do cardiac catheterization unless there's a really either patients with very difficult echo windows where you can't really adequately do the TR jet velocity. I think that specificity is, I agree with you, that's what's in the literature. I think it changes if you have a unit that is expert in doing this and the same people doing the same thing over and over again. I think that that's one of the problems. There is a subjectivity, as there is in most forms of imaging. However, it's still a very valuable tool in your individual patients that you're looking after clinically, particularly if you see trends upward. And as I said, some of the physiology is affected by the chronic anemia. So in a hyperdynamic situation, in someone with a profound anemia, then the velocities are higher just by the nature of having hyperdynamic circulation, and you'll tend to measure higher velocities. Doesn't necessarily mean they've got problems with blocked pulmonary resistance and capillary vessels. So yes, adding a BNP, yes, it can be useful in those patients that you really need to be worried about. We tend to do it if we do think there's some doubt about it, and it will help in some degree. And yes, I think it would be better having a package, if you like. So it's not a single parameter you're depending on, but you're depending on the TR jet velocity, the BNP levels, ECGs, patients themselves, etc., etc. Quite what that would look like in practice is difficult to be certain about, but the BNP is very valuable. But there again, caveats there about the specificity, because a stretched right atrium can occur for many different reasons, including a burst of arrhythmia, and you can get a falsely elevated BNP. But yes, we do it, and it does help differentiate. So a useful tool to help establish who really does need treatment specifically for their pulmonary hypertension.
Thank you.
There's a question in the chat from Dr. Masali at North Middlesex Hospital regarding indications for cardiac transplant in sickle cell disease.
That probably comes from a conversation I had this morning. The difficulty is these patients are multiply transfused, and so many have antibodies. Secondly, the availability of donors in the ethnic groups is difficult. It's difficult in everybody. We have discussed, but never successfully achieved, referral for transplantation. But certainly in the thalassemia group, it has been done, mostly in Europe, and I'm not sure about the US, to be honest with you. So it is very low, and a very much an end stage issue, which is a paradox, because the transplanters don't want to take people. Emergency transplants have a much poorer outlook than something that is done in a more planned way. So it is a really difficult discussion, and often made impossible because of the transfusion history and the development of antibodies.
Thanks. And I had one other question, which was related to the availability now of potentially curative treatments for sickle cell disease in the form of bone marrow transplantation and gene or genetic therapies. Can we identify which patients are at risk of developing these catastrophic cardiac complications who might at an earlier stage benefit from curative therapy.
I hope so at some stage, but I've been singularly bad at it so far. There's some are very obvious to you and I. You know, the people with a very severe phenotype with lots of hemolytic episodes, vaso-occlusive episodes that just persist no matter what you try and do. Yeah, I mean, yeah, we are not good at this, at teasing out, even from within, you know, the 10% with problems, those that will go on to these catastrophic manifestations. Not yet there, and that's why I hope by doing this kind of surveillance, doing more detailed cardiac phenotyping with things like BNP, other biomarkers, and MRI imaging, will build up a picture that I hope will be useful in the future. But it's not there yet, that's for sure.
Thanks. And just lastly, a sort of practical clinical point. I think many of us in our guidelines for sickle cell disease and recommendations on managing blood pressure follow fairly standard advice in relation to blood pressure control. You were suggesting that we should probably lower the targets in sickle cell disease patients.
That's my hypothesis. You know, the trouble with that is I can't see anybody ever doing a prospective trial. But even I think if you looked carefully at and I haven't, I have to say, I would be I hope that actually people achieving even what the standards are saying today. I think they would do better by actually being more intensive at a younger age in this group, as I would in anybody whose heart is facing abnormal loads over a lifetime. I think most of the data shows that those people that have good survival tend to be the ones with the lower blood pressures, the better general holistic approaches to their care, which includes diet, exercise, and all the rest. So, you know, I can't rewrite those, but you have to examine the data upon which that advice was made in the first place. It was probably extracted from the general population. And my point is that that's probably incorrect for this group.
Thank you again, Malcolm. Well, if there are no further questions, it just remains for me to express our gratitude to you for such an informed and insightful view of a subject that I think we all struggle with clinically, and we will post the talk on the HCC website, so I hope many more people will have an opportunity to gain from your expert views, and we'd very much welcome you back again at some point in the future to get an update. So,
and remember that name of Polyvios Dimitriadis, because I hope he's very interested. His cardiological curiosity has been piqued by me introducing him to this clinic, and he's a very energetic young guy, and I think I hope that you guys will get to know him and begin to work with him so that some of these questions can be answered. It's an incredibly important field.
Yeah, many thanks again.
Okay, thank you very much for listening, everybody.